Good evening. I'm Debbie Charles. I'm a breast cancer advocate with Georgetown Breast Cancer Advocates in Washington, D.C. And I'd like to welcome Dr. Virginia Kaklamani. Thank you very much for coming and talking to us tonight.
Thank you for having me.
And so what can you tell us about the Thursday events today, the presentations, the posters? What did you see that was of interest? What was maybe groundbreaking?
So what we looked at was different molecular assays that could help predict our treatment, could also help predict how well our patients with breast cancer are going to do. We've had some of these assays in the past, and now there's a development of a couple more. So this is kind of a growing body of evidence where we're trying to find ways to look at the genes in the breast cancer. And those genes are going to tell us a story. They're going to tell us how well a woman's going to do and what kinds of treatments are going to work for that specific breast cancer.
So is this something that it'll help patients now, or you see this as helping patients down the road once you figure out what to do with that knowledge?
I think, well, some of those molecular assays are already available and we use them commercially available. And the question is, which one is the best one? We still don't have the answer to that. We have a lot of them that work well. I think what the new data that's coming really is focusing on the chemotherapy aspect of that. So we know that by doing those assays, you can tell a woman what her chance of her breast cancer coming back is. But the most important thing is, how can I change my treatment without compromising what your chances are of your breast cancer coming back, or hopefully even making it even better?
Was there anything specific that for one specific type of cancer or specific, either metastatic cancer or maybe the people who have early stage cancer, was there anything special that you saw that might make an impact on the patient themselves and the treatment that they have?
Yes, so one of the studies that was presented looked at a specific molecule that binds the gene of the estrogen receptor. And by binding it, it helps pretty much deactivate it in a way. And remember that estrogen receptor is being used as a growth factor for the breast cancer cells. So once you bind it and you deactivate it, all of a sudden it doesn't work and the breast cancer cell dies. Now this was relatively early work. This molecule was used in mice, and many times in the history of breast cancer and cancer, we've cured mice. We are still trying to cure more patients, but it's very promising. And so what the researchers are doing is, because they're seeing that this molecule can be developed for use in patients, and this is their next step. Their next step is to try to do the studies to make sure it's well tolerated, and then try to see how well it works in our patients and also in combination with other treatments that we have available for estrogen receptor positive breast cancer.
And is that something, the results, the things that we saw, the results of the different studies that were presented today, do you see any impact on, say, clinical work now, on something, what sort of options you would offer to patients today or, in the near future?
So some of the studies that were presented today had to do with the choice of surgery. It took us a long time to go from a radical mastectomy to a partial mastectomy, and we are almost talking in some cases about maybe not even having to do surgery. But then when you look at the trends and how women are choosing their surgeries, probably because of fear, they're going back to having more and more mastectomies. And the thought has always been, well, if I remove my breast, then my breast cancer is not going to come back. Well, remember, the breast cancer that comes back typically doesn't come back in the breast area, it comes back in other parts of your body, so removing your breast doesn't make a difference. And there was a study that was presented out of the Netherlands, which was a study on 37,000 women, so a lot of patients, where they compared the women that had a lumpectomy to the women that had a mastectomy, and they actually showed that the women that had a lumpectomy did better. Now this is a study that we have to really dwell into and kind of see what the nuances of that study is, because I don't really want to be suggesting to women that if they have a mastectomy they're not going to do as well. But it really tells us that having a mastectomy doesn't really benefit them.
Right. I suppose that would depend on the type of tumor that you have and how big it is.
Assuming that you can take it out with a lumpectomy, and that's the key. The key is to take out the cancer any way you can. Now another study looked at the economic benefit or burden behind these surgeries. When you have a lumpectomy, that's a typically small surgery. A woman doesn't even have to stay in the hospital. She gets released and goes home the same day. She doesn't need reconstruction. If you have a mastectomy, you may need reconstruction, which means more potential complications. And so a researcher out of MD Anderson in Texas looked at the economic burden of the different surgeries that women had. And obviously he found that women that elect to have a mastectomy and reconstruction really end up having a much more higher economic burden. They may have more complications. They had twice as many complications as women that had a lumpectomy. And so when you're tying those two things together, the lack of benefit of a mastectomy and then the increase in complication rate, increase in economic burden, then you really have to think about it as a patient and really what surgery is best for me.
So it seems like with these results about the surgery and things we saw yesterday, the theme that seems to be evolving in the conference is that less is more. Is that
Absolutely. You want to give the right therapy. You don't want to just give therapy. We have a lot of treatments available. We have chemotherapy. What we've learned from the genomic tests is that we can avoid chemotherapy in 50, maybe 75% of early stage estrogen receptor positive patients. That's huge.
And that's a big population,
That's
right?
a big population. 60, 70% of our breast cancers are estrogen receptor positive. So if you can avoid chemotherapy in the majority of them, that helps side effects, it helps so many things, not to mention, again, economic burden on society and on those patients. And the other thing that we're learning is that we can identify the kind of breast cancer, the subtype of breast cancer, and then tailor our therapy based on that subtype.
Wow, that's a big advantage and a big change, right?
Absolutely.
And I know that this symposium is international, and you're getting a lot of people from all over the country, all over the world presenting. And how likely is it that they can actually use some of the results? I mean, are these results good for maybe developing countries, maybe countries where there isn't as much advancement in treatment of breast cancers? Do you have any thoughts on that?
So we have around 8,000 people that attend, and at least half of them are from elsewhere, not from the United States. Every country is unique in the resources that they have, and also different ethnic groups have different responses and different toxicities from chemotherapy. For example, yesterday a study was presented out of Japan and Korea where women were given capecitabine in form of chemotherapy for 6 months. And the dose that was used was a little higher than what we use in this country. And what they found was that the women that received the chemotherapy lived longer and really had minimal side effects. When in this country, we actually have quite a few side effects from this medication. And the question is why, and some people think it's because we have a very high folate diet, and that can interact with the capecitabine. But regardless, when that was presented and people were excited about it, we realized that for us in the United States to take this and to apply it to our patients, we'll have to do our own study and see really how toxic is this medication. And the other way around, we talk about mammograms, for example. Should we be having mammograms or should we not? Well, some countries don't have access, and some women don't have access to mammograms, and we're talking about 3-dimensional mammograms. So,
which are expensive.
Which are expensive, and in many places not available. So it really does make a difference. But the good thing about the symposium is people can attend here, but sometimes people obviously can't come to San Antonio. We have what we call Best of ABCF, so those are series of conferences that take place all around the world. Canada and China and Japan and Argentina and Brazil and Saudi Arabia and India. And so researchers that come here go over there, they have a symposium for 1 or 2 days, and they present to their colleagues what they learned from the symposium here.
Oh, that's great. It's a good way to teach it and everything. And what about these patients who are, say, listening to these sorts of presentations online and things? What do you expect to hear from patients who haven't attended this conference but who heard about it, read about it, saw an article, watched a YouTube video? Are you expecting, do you think that doctors are going to have any impact from any change in what their patients are requesting? Or
Absolutely. Every Monday morning after SABCS, we get a lot of phone calls from our patients. It has to do with, is this test available? Should I get tested for it? What about this drug? Should I be taking it? Am I getting the right medication right now? And so women pay attention, and they should. And the good news about SABCS is the novel things that are presented are all over the news, and women learn about them and then quiz their doctors, and we better be prepared.
Yeah, and that's good, right? It's not bad. It's not second-guessing
Not at all.
The doctors.
We need to be second-guessed.
Yeah. Well, good. Well, thank you so much for your time. I appreciate your insight, and we look forward to more days of interesting presentations.
Thank you so much.
Yes.